people can still see this. So welcome to Sliding Fee Scale and Caps on Patient Charges. We are very excited to have you today. I see that some people are asking about sound. Now you should be hearing it. If for some reason you don't, please let us know. I am very excited to present Jenna Collins, but before we begin, I'm going to take care of a few housekeeping items. So just a little bit more about Health HIV. We work in 4 core capacity areas: capacity building, advocacy, health services, research and evaluation, and education and training. And we work across HIV, hepatitis C, and LGBT health. I manage the Fiscal Health Systems to Sustainability team. We are funded through a HRSA-HAB cooperative agreement to provide training and technical assistance to Ryan White-funded organizations on all kinds of fiscal areas, from grants compliance, uniform guidance issues, sustainability. If you have any questions on topics like preparing for a HRSA site visit, anything you hear today, time and effort reporting, we are very happy to help you with that. And our information will be available on the slides as well. So we have a number of materials available for you to download today. We have the PowerPoint slide deck. If you go to this little folder icon, it's on the bottom right-hand corner of your screen. We have the slide deck. We have a number of different tools that will be discussed during the presentation today. They are all in Word format so that you can tailor them to your health organization. So again, you can make the changes that you want. If you want to check with us to make sure that they're still compliant or that they're useful, please go ahead. We also have a link for our evaluation. It would be really helpful if you took a few minutes afterwards to fill it out. This webinar is also being recorded. It will be available on the Target Center and on our website. We also will be obviously accepting some questions and we'll be responding to them. We're going to wait until the end, though. There are a number of you, as you can see, who are on the webinar today, and for the sake of time, we're going to take all questions at the end. However, we are going to be monitoring the chat box throughout the webinar today, so if you want to ask your questions, we'll write them down. If you have a very specific question, we might not be able to get to it, but we will follow up with you so that you get all of your questions answered. I'm also going to put my email address in the chat box so that you can email us directly with your questions. We know this is a very hot topic, and so we are here to help. And again, the chat box is down here. A number of you have already been using it, which is great. You can also send us a private message. If you click on Anna Ludwig, you can click on it and say send private message, and you can chat with us directly if you have any issues. Before I hand it over to Jana, I will just introduce our speaker today. Jenna Collins currently serves as the Research Protocol Manager for HIV programs at the Ryan White HIV/AIDS program-funded Bluegrass Care Clinic at the University of Kentucky, where she has worked in various capacities since 2002. Over the past 11 years, she served as the Program Coordinator and Financial Manager for Ryan White Part C and D programs there, as well as the Financial Manager for their Part B and AIDS Education Training Center subcontracts. So she is very well versed in all of these issues across Ryan White Parts. She's also served as a fiscal, administrative, and technical assistance consultant for HRSA, participating in diagnostic site visits for Ryan White recipients since 2008. We are very excited to have her today, and Jenna, I'm handing it over to you.
Thank you, Samantha, and thank you to the Health HIV team for seeing the importance of this topic and giving me the opportunity to present to my fellow grantees throughout the United States that are serving HIV patients. So I hope today that you will have a good framework and understanding of the sliding fee scale and a cap on charges. I'm going to kind of set the framework for this talk, and then we'll move through each of the topics at length. And then at the end, I'll be happy to answer questions if they're super specific to your organization. That may be something we can't dig into today, but hopefully we can, through the Health HIV staff, get you the assistance you need to move your program forward. So we're going to talk about several elements associated with the sliding fee scale and cap on patient charges. I want to first talk about the Ryan White requirements related to patient payment for services, because the legislation is pretty specific about that. And then we're going to kind of talk about the parts of the circle of client management. There's really several parts that fit together to make a whole management system that programs really need to have in place to be in compliance with Ryan White legislation and program guidelines. So we're going to talk about the expectations of enrollment and eligibility, and then in those frameworks we're going to discuss the sliding fee scale, cap on out-of-pocket charges, and I'm going to touch program income very briefly just to let you know how these all kind of fit together to enhance your program. So by the end of this session, hopefully you will be able to develop a sliding fee policy for your organization, or if you already have one, beef it up and make it stronger, how you can implement a sliding fee policy for your program, and then we're also going to talk about how you can calculate the annual limitation of charges for patients based on their income. So from a fiscal and administrative standpoint, there's really 4 stages to client enrollment, and the first stage starts with enrollment and eligibility. Programs really have to have a way to identify who is eligible for Ryan White services and identify all of the potential payer sources. Since Ryan White is to serve as a payer of last resort, this process of enrollment and eligibility is really the essential starting point for your program. And then based on the information that you receive during enrollment and eligibility, you use that to place a patient on your sliding fee scale or discount schedule. For patients that are over 100% of the poverty level, you will assign them a cap on out-of-pocket charges. And then the final stage of this is managing the patients and keeping track of the income that comes in from the insurance payers that you have enrolled the patient in, from the patient themselves if they're paying on a sliding fee scale, and reinvesting that back into the program. So really all 4 of these stages are necessary in order for you to be in compliance with legislation and Ryan White program guidelines. So I want to go ahead and define up front how some of these things will be presented. So when we're talking about Ryan White requirements, there's typically 2 types of requirements that they fall into. One is program expectations and the other is legislation. So program expectations are what you're typically going to find in the funding opportunity announcement when you get the instructions to write your initial grant application, or you'll find those in policy notices or letters that are released by HRSA-HAB. But those are typically referred to as program expectations. The second format is Ryan White legislation, and that is directives that are directly taken from the Ryan White program legislation. And so when you have a site visit and the consultant team presents findings, they're going to present them as a program expectation or legislation. And the bottom line for us as grantees is that we have to be in compliance with both. So if you have a site visit and you have a finding that you have a weakness in an area of legislation or a weakness in a program expectation, those are areas that you're going to work with your project officer to fix. And so I'm going to present today much of this information. I would say all are legislative or program expectations for programs. So they're really systems that we are all required to have in place. So the first thing I want to start out with is the Ryan White legislation as it relates to payment for services, patient payment for services. So first, the legislation prohibits imposing a first-party charge on individuals with income at or below 100% of the poverty level. So if a patient walks in your door and based on your enrollment and eligibility process is determined to have an income under the federal poverty level, based on Ryan White legislation, they should not be charged for services, and they should be provided HIV outpatient care through your Ryan White grant program. The extra step to this that some programs tend to miss is that the legislation requires that individuals with income above the poverty level be charged for services. And so this is what I often find when I go to a site. Everybody is great about not charging patients. It's the easiest thing to do. If you want a patient to come in the door, you don't want them to get a bill, don't charge them for services. But unfortunately, the legislation specifically says that there's a population you don't charge, but there's a population that you are supposed to charge for services. And that's where the sliding fee scale and cap on charges comes into play. And the framework I always try to tell people is that Ryan White programs are designed to honestly help everyone. The assistance that a patient gets will vary based on their income, but particularly for Part C and D programs, our limitations is a patient that's HIV positive. And really, when you look at the sliding fee scale and you look at the cap on charges, any patient can be served within those guidelines. They may pay more, they may pay the full charge, but they are still assigned a cap on charges, and if something catastrophic happened or if they couldn't pay, that patient would still be provided services. So I think the important thing when you think of enrollment and eligibility, when you think of the patients that are eligible for services, think of it that all patients could technically be served by a Ryan White program. It's just their assistance is going to look different depending on where they fall in the program income. So what we're looking for, particularly when we come for a site visit, is that you're going to have policies and procedures in place to show that this is happening related to screening and eligibility. So we're going to be looking for that you're verifying your patient's financial status when you meet with them, that you have a sliding fee scale that you're implementing and you have a policy and procedure related to this, and that you have a policy and procedure related to your cap on patient charges for HIV-related services. So I wanted to say that when, even though having policies and procedures is not enough, that would be the first thing I say. It's important for you to have a framework for your program to work in. So it's important for you to have policies and procedures written for each of these areas. But you also need to be able to show that this is actually happening on the ground. You should have documentation that patients are completing enrollment and eligibility applications. You should have evidence that patients are applied a place on your sliding fee scale and that they are assigned a cap on patient charges. You need to have staff. This obviously requires manpower to meet with patients, to enroll them, to determine their eligibility for insurance. So you have to have the staff to carry out these processes. And most importantly, your patients need to be aware of these services. It's vital and a requirement for Ryan White programs that patients know that they can come to you, that they can be seen for HIV care and not be required to pay. And if they're unable to pay, they'll still be seen and they'll be provided care. So the most important thing is that there are patient education materials that you can provide to your population to help them understand what services are available because you are a Ryan White funded entity. So let's start by looking at enrollment and eligibility. So as the payer of last resort, it's important, vital, necessary that all Ryan White programs look at their patients and see what programs they might be eligible for. So Ryan White legislation requires that individuals receiving Ryan White services have the diagnosis of HIV and be low income. So as I said earlier, we'll discuss with the cap on charges that even though your program may define a patient as low income at, say, 400% of the poverty level, the cap on charges doesn't have a cap. So patients who have incomes above that can still be extended potential assistance as you put these systems into place. I do want to make a quick comment on Parts A and B. You'll see in Policy Notice 10.2 that Parts A and B can not broaden the definition of who's eligible, but they can be more restrictive. So often Part C and D programs will be subrecipients of A and B and will have some limitations on some services of who they can provide. For instance, the ADAP program for the state may cap out at 400. Those things exist, and that makes your enrollment and eligibility process all the more important because that helps you identify what patients will be eligible for what services. You know, will this patient be eligible for Part B, or are they just eligible for Part C? And that should really be built into your eligibility process if you have multiple funding sources for your program. But as I said before, for C and D, there's really no limitation on the patients that should be served. It would just, how much they have to pay out of pocket would be determined by their income. So let's talk about first what's needed for enrollment and eligibility. And I'm going to refer to Policy Notice 1302 because they have a really nice chart that I'm going to present as well. The first thing that you have to have is the client's HIV status. That's really something you just need to get initially and keep on file. That's not something you have to require during this annual re-enrollment recertification process. That's something you just need to get up front. But initially and annually thereafter, you need to have a system in place to get documentation for the patient that assesses the patient's eligibility for insurance and proof of enrollment if the patient's eligible for insurance, their proof of income, their family and household size, and proof of residency. So that information should be collected at least annually. Programs for enrollment and eligibility, like I said, should have it at intake and annually thereafter, but there should also be an established process to recertify patients every 6 months. That's sometimes called a 6-month attestation, where you kind of check in with the patient to see if anything has changed over the last time period, but you don't necessarily have to repeat all of the documentation, which is what we're going to go through now. So in Policy Notice 1302, there's a nice chart of the documentation that's required annually versus every 6 months. And so I wanted to go over that briefly. Again, HIV status is something you only have to get once. Income and residency information is required at least annually. So when you do your 6-month check, if the patient has had no changes in their income or their residency information, then you do not have to gather that information again to prove that. You just need to have a form that the patient signs that says there has been no change, and we'll go over that more in a minute. Same with insurance status. This is something you definitely want to reevaluate at 6 months to see if the patient's had any circumstance changes that may make them eligible for an insurance program that they weren't eligible for 6 months ago. So that should be part of the 6-month assessment, is just to check in with the patient, say it's during open enrollment, making sure that patient's enrolled during open enrollment if they missed the cutoff last year. But that should definitely be an assessment that takes place at 6 months. And then the chart mentions CD4 and viral load. That is not a requirement for enrollment and eligibility. That's really at the discretion of the program. If you want to require patients to maybe that you don't see on site that get HIV care elsewhere to provide CD4 and viral load information, that's at your discretion. So the self-attestation of no change is basically a form that a patient certifies that they have not had any changes in the last 6 months. And so they're going to specifically identify each of the eligibility criteria, medical insurance, income, residency, and household size, and say, you know, no, I have not had changes in each of these areas. And the client can sign the form that says that they, you know, certify that this is true, and then the recipient will have documentation that they've done their 6-month check with the patient. So here's an example of a self-attestation. Basically, it would just have the patient's name. It would give them the opportunity to check each of the areas to say they don't have any changes in these areas, but it's also good to add a caveat statement that says, you know, so the patient knows if they do have changes that they should talk to program staff, you know, within the next 6 months, you know, before they're up for their year renewal. If they have a change that would affect their eligibility, they should tell program staff. You know, if they lost their job and they've had a cap on charges, but now they have no income, they really need to talk to program staff so that their assistance may be at a greater level. The self-attestation of change is an option for programs, and that would be something you could use instead of having the patient fill out a full application at 6 months. And basically, the patient would be identifying that there has been a change in eligibility criteria and give them the option to disclose that. So the form would say, yes, I've had a change in insurance, yes, I've had a change in income, and then the patient would provide backup documentation so that the recipient would have that on file to show that they've done a 6-month recertification. And this is what a self-attestation of change form could look like. Again, the patient's name is associated with it. They can check which areas they've had a change, and then they can say, you know, this is my new insurance, this is my new income, my household size has grown or decreased, this is my new address. So this just gives you a format to meet with the patient It's probably less than a full form that the patient would fill out each year to establish their sliding fee scale and cap on charges, but gives the patient the opportunity to say, yes, something has changed, and this is how we need to react. And again, any documentation that the patient has to support that information that you normally require, if that's a bill or you know, 2 pay stubs, whatever you require, that should be attached to this form so you have that documentation on file. So really the enrollment eligibility process is really the key to making all this happen. You have to have a system in place to identify each of your patients that are Ryan White eligible and have them apply for your sliding fee scale and your cap on charges. So this kind of kicks off the other processes. So let's move to a discussion of the sliding fee scale and discount schedule. So going back to the legislation, as I stated before, particularly Part C and D programs, clients cannot be denied services if they are not able to pay for services. But Ryan White programs have to provide a system to track patients' income, discount patient payment for charges by developing and utilizing a sliding discounted fee schedule that is available and published and made readily available. And the fee schedule may be based on either the patient's income or income and household size. So that is directly out of the Ryan White legislation that programs have to have a sliding fee scale in place for their patient population. And I think this is where it gets hard, is that each program has to create their own sliding fee scale. And the only guideline that's really attached to this is that it has to be in line with the most recent federal poverty guidelines. So as many of you know, those are released by the HHS website, usually between January and March. So that's something you'll have to keep an eye on to update your forms and policies and procedures. But that's really the only guideline with the sliding fee scale. Outside of that, programs can design the sliding fee scale however they want, as long as it's in line with the legislative requirements of patients under the federal poverty level not paying for services and patients above the federal poverty level being charged at least a nominal fee for their services. So in a way that's really good because all programs are different. We all have the same instruction book, but we have different, different climates that we exist in, different organizations, different patients that we serve. Some are rural, some are urban. We all look different. So it's really within the discretion of the program to design the sliding fee scale that works for you and your billing department. I just want to say, if you can involve your billing department and automate this as much as possible, this will make your life much easier. And so when I present these slides, sometimes a nominal fee is possible in billing systems. Sometimes a percentage is easier to talk to your billing folks into. And so as you set up the sliding fee scale, if you can have yourself set up as an insurance for your program and if you can have yourself set up similar to an insurance in your billing system, that will help automate a lot of these systems. So here is a shot of the 2016 federal poverty level, and we'll be using this for some case studies in a bit. So I wanted to talk for a second about Ryan White and other sliding fee scales. So a lot of organizations already have a sliding fee scale, particularly if they're a community health center or a disproportionate share hospital, they may already have a sliding fee scale for the organization. And oftentimes people ask, can we just use the sliding fee scale that already exists at our organization? And if it's in compliance with the Ryan White legislation, absolutely. It would be easier to tack on to your agency's sliding fee scale. I would recommend to use that. But if it's not in compliance, you're likely going to have a sliding fee scale that is unique to your program. For instance, community health centers, I believe they can allow a minimal nominal fee for people who are under 100% of the poverty level, and their sliding fee scale usually caps at 200%. So often community health centers will have their organization-wide sliding fee scale, but they'll also have one that is Ryan White specific, so that the patients who are enrolled in the Ryan White program have assistance that's based on legislative requirements. So if your sliding fee scale is not in compliance with your organization, then you will need to develop one that's specific to the Ryan White program. For community health centers, like I said, they would have to identify that if the patient's a Ryan White patient, they would not be charged the nominal fee that they're charging other people who are below 100% of the federal poverty level. So it's always a good place to start. Look at what your organization has in place. Look at how it's set up in the billing system, because maybe you can be set up as a Ryan White program similarly to what the sliding fee scale in your system already looks like, but just maybe a little more restrictive, or have the modifications made that are specific to the Ryan White program. So let's talk about what a nominal fee is. And really, again, this is at the discretion of your organization. I mean, by definition, a nominal fee is minimal in comparison with real worth or what is expected. So it's really just a small fee that is charged to a person for services. And sometimes that is to give that person I guess accountability or some participation in their medical care. Patients that are above the federal poverty level, the expectation is that they would pay a little for their personal involvement in their medical care. There's really no fixed definition on what a nominal fee is, and that's really up to your organization, and it can be a flat rate or a percentage. So really, a nominal fee may cover a wide range of the actual cost. It's not going to cover the cost, but it would be a portion so that the patient can participate in their medical care financially. So let's just look at a sample sliding fee scale based on a nominal fee. So if you have a patient that's below the federal poverty level, of course, their nominal fee is going to be nothing because that's in compliance with Ryan White legislation. But then if you move from there, you could set it up where a patient that's between 100 and 150% of the federal poverty level pays $5 for a medical visit, all the way up to, say, $25 if the patient's between 300 and 400% of the federal poverty level. And then if a patient's over 400% of the federal poverty level, maybe they'll pay the full charge for services up to their cap on out-of-pocket charges. So this is just an example of what a nominal fee schedule may look like for a program. So to kind of drive the point home, I just want to look at a case study. So if you have a patient that comes in your door that has an annualized income of $14,916 and, say, a household size of 1, that means their federal poverty level is 125%. So for example's sake, let's say this patient also has Medicare. So based on your sliding fee scale, the nominal fee for this patient would be $5. So if they complete an HIV-related medical appointment, Medicare, since they have Medicare insurance, would be billed first. So you would look at the patient's responsibility after Medicare. So for example's sake, let's just say the patient balance was $51.25. So if you extended your sliding fee scale on top of Medicare, then that patient would pay a nominal fee of $5 instead of the $51.25. And the grant would assist the patient with the $46.25. Sometimes that looks like a write-off if the provider was initially funded by Ryan White funds. Sometimes that would look like the Ryan White would be supplementing that patient's copay by paying the organization that provided the services the $46.25. But essentially, the patient is participating in their care. They're financially paying or being charged an amount for their service, but they're not paying the amount or being charged the amount out of pocket they would be if they were not at a Ryan White program. And so I think that's the important thing, is that there's the difference between helping a patient with their responsibility and balanced billing is pretty different. When you look at charging a nominal fee or charging a percentage, you're really looking at what the patient would be responsible for out of pocket if the grant did not exist. That could be a co-insurance, that could be a co-payment if the patient has insurance, or if the patient did not have insurance, that would be a discount on the full charge. What this is not, and what's prohibited, is that if your organization has agreed to accept $150 for a service that actually costs $200 to provide, you can't balance bill Ryan White grant for that $50 that is just kind of lost, I guess. The grant is assisting with and paying for is what the patient would be responsible out of pocket, not the difference between the full charge and what insurance has agreed to pay. So now let's move to a sliding fee scale that is a nominal fee based on a percentage of charges. And this may be an option for programs whose billing system can't accommodate a nominal charge. So I like to present this as an alternative. So basically, for a patient that's below the federal poverty level, of course, their responsibility would be 0%, but you could go up from there. If a patient had a federal poverty level between 101 and 150%, they could be responsible for 10% of the charge, up to 80% or full charge, whatever sliding fee scale you felt was reasonable for your patient population. Again, all of this would be capped at the patient's cap on out-of-pocket charges, which we will talk about briefly. So let's look at an example of what a percentage might look like. So again, you have an HIV positive person that has an annualized income of $18,576, household size of 1, and their federal poverty level is 159% of the poverty level. And let's say the patient has private insurance. So the patient completes a medical appointment and their insurance requires a co-payment of $50. So what you can look at in terms of a nominal fee for this patient is the patient being responsible for, say, 20% of the copay, which would be $10 based on your sliding fee scale. So the patient would pay the $10 of the $50 copayment, and then the Ryan White grant could assist the patient with the remaining copay, the $40. Again, that would be a write-off, or the grant could actually pay that copay to the organization that provided the services if the providers weren't paid for by Ryan White funding initially. Let's look at another case. So this is a person that's living with HIV. Again, their annualized income is $26,450 with a household size of 2. Their federal poverty level is 165%. And during your enrollment and eligibility process, you assess them for insurance, but they do not have insurance options. So they're going to be a patient who's going to be required to pay the full charge. So if they complete an HIV medical appointment and say the full charge of the appointment for your organization is typically $150, then if based on the fixed rate nominal fee, the patient would pay $10 of that $150 charge. So again, even if you have an uninsured patient, this sliding fee scale would be applied to them, and they would be only paying a portion of the charge that was provided, and then Ryan White would be assisting with the remainder of those charges. Similarly, if you use the nominal fee sliding fee scale that was based on a percentage, if the full charge was $150, the patient's nominal fee would be 20% of that $150, which would be $30. So even though there's a difference, the nominal fee, sliding fee scale was $10 for the same patient, the percentage was $30. That's going to happen, and it's really at your discretion how you set up your sliding fee scale. But the important thing for the patient is that their out-of-pocket charges should not exceed their cap. So regardless of how much you come up with in terms of how much they pay as a nominal fee on your sliding fee scale, they know going up front into care that their out-of-pocket charges for outpatient care should not exceed the cap that is established during the enrollment and eligibility process. So having said that, let's talk about the cap on charges and what that looks like. So the Ryan White legislation limits the annual cumulative charges to an individual for HIV-related services based on federal poverty level, which is gross annual income and income made before taxes and other deductions are taken out. So Ryan White Part C programs, based on legislation, are required to have a system in place to ensure that these annual caps on charges to patients are not exceeded. So the organization should track the patient's income and the charges imposed on the patient towards their cap on charges, and then should assist the patient in also tracking charges that are imposed maybe at other programs. If all of the HIV services that patient received aren't provided on site, and say they receive mental health services elsewhere and they're paying a portion there, then that patient could bring in invoices or receipts to show other charges that they are responsible for out of pocket towards their HIV care, and that can be applied towards their cap. So according to legislation, patient caps on charges should be calculated and updated annually. based on the charges imposed and non-on payments made. That's very important. When you are tracking a patient's cap on charges, you don't have to have proof that the patient has paid the charge. You just have to have proof that the patient has been charged that amount. If the patient's paying on a payment plan or is finding assistance somewhere else, that is not something you have to worry about. You just have to worry about showing documentation that the patient has been charged for these HIV-related services. And then the caps on charges based on policy notice 1305, 1306, and 1401 should include any of the patient's out-of-pocket responsibility in terms of like premiums, co-payments, and co-insurance. So the cap on charges is something that is defined in the legislation. And so if a patient receives care in Iowa and then goes to Florida, if they have the same income, their cap on charges should be the exact same. So if a patient's, of course, under the federal poverty level, they have no responsibility and no cap on charges. But if the patient's federal poverty level is between 101 and 200%, their cap on charges should be 5% of their gross income. If their federal poverty level is between 201 and 300%, their cap should be at 7% of their gross income. And if their federal poverty level is over 300%, their cap should be 10% of their gross income. So again, I want to point out that there's not a cap on the cap. So any patient with any federal poverty level can be extended the cap, and they may not get close to meeting it year after year, and then one year if they have some catastrophic event happen, they meet their cap, and then the program can assist them at that time. So any patient with any income can really be extended and should be extended a cap on out-of-pocket charges. So let's revisit our case studies, going back to case study 1 with the patient who has an annual income of $14,916 and a household size of 1 and a federal poverty level of 125%. Based on the legislative requirements, their cap on charges would be $745.80. So that would be 5% of their income. And if, again, this patient has Medicare and a nominal fee of $5. So when they're charged that nominal fee of $5, that is applied towards their cap on out-of-pocket charges. So I want to stop and say that a lot of times grantees, recipients will get overwhelmed by this idea that we have 2,000 patients and this is going to be a manpower issue and there's no way we can manage this. And I do want to say that this doesn't apply to every single patient. It only applies to the patients who have a federal poverty level over 100%. And so for my own program, I went to look and see how many patients. We see 1,185 patients in 2015. So we had 334 patients that had a determined cap on out-of-pocket charges. So that was 28% of our patient population. And we had 87 patients that met their cap. So 7% of our patients actually met their cap and were dropped down and helped as if they were under the federal poverty level for the rest of the grant year. So it typically affects a very small percentage of your patients, but for those patients, it makes a pretty big difference. And we have some patients that have heavy premiums up front, and even though we may not be able to help them with premiums, that will help them meet their cap, and so we can help them with their outpatient expenses for the rest of the year. Sometimes patients will have kind of a catastrophic inpatient or ER visit that's HIV related, and even though we can't help them with that, we can apply that charge to their cap on out-of-pocket charges, and we can assist them with their outpatient care and hopefully keep them out of the ER and keep them out of inpatient again. So there are ways that this helps patients that will help patients to stay in care. So it's very important for the patients that it actually helps. It may not be every patient that walks through your door, but there's going to be a percentage of your patient population that this really benefits. So again, looking at case study 2, where we had a patient with a federal poverty level of 159%, their cap on out-of-pocket charges would be $928.80. And so when they paid their nominal fee of $10, that would be applied towards their cap on out-of-pocket charges. And then we had the case study 3, where we had a patient that did not have insurance. And again, their cap based on their federal poverty level would be $1,322.50. And their charges, whether it be based on a percentage of charges, which was $30, or based on a fixed rate nominal fee of $10, both of those charges would be applied to that patient's cap on out-of-pocket charges. So regardless of what you determine to be the nominal fee or the percentage that a patient's going to have to pay for services, that cap is what the patient knows, this is all I'm going to be responsible for this year, if I even get there. Like I said, some patients don't even reach their cap, but there are some that do, and they know that that's what their out-of-pocket responsibility is going to be. So let's look at a new case study specifically related to the cap. So you have a new HIV diagnosis with an annualized income of $49,200. The patient has a household size of 2, which makes their federal poverty level 307%. So their cap on charges is $4,920. And during the enrollment process, the patient's assessed for insurance and would be eligible for Marketplace, but it's not open enrollment, so that patient can't be enrolled at this time. So they show up at their next appointment, and they were diagnosed inpatient and had a hospital stay due to PCP pneumonia, so they have a bill for $12,000. So that bill, even though you can't help with it with Ryan White funds, you can apply that bill to their cap, and the patient meets the cap immediately. So that means for the rest of the year, the patient's not charged for HIV-related outpatient medical care, and he receives the outpatient medical services he needs from the Ryan White program because he's met his cap. And then you should have in your enrollment and eligibility files a tickler that when open enrollment comes open, this patient needs to be assessed and enrolled in an insurance plan at that time. So that's how Ryan White would assist a patient in this scenario. So I do want to talk about program income just briefly because it kind of brings all of this together. Program income is the gross income earned by the recipient that is directly generated by supported activity or earned as a result of the federal award. So program income is typically generated in these scenarios by subrecipients and recipients who are charging for services and receiving payment from third-party reimbursement, whether that be insurance companies or patient payments on the sliding fee scale. So it's the responsibility of the recipient to monitor and track program income. And under this additive alternative, which was referred to in the policy notice 1503, this income should be used for the purposes that the award was made for the HIV program and can be used for allowable costs under the award. So if programs are completing the first 3 steps correctly, enrolling eligible patients, assessing and billing insurance as appropriate, and charging patients who have incomes greater than 100% of the poverty level, then the program will have some program income coming in that needs to be tracked and reinvested back into the HIV program. I think this has changed a lot with ACA. Pre-ACA programs may have had minimal income because we had a pretty large population that was uninsured. But with the availability of insurance with ACA, and with many Part A and B programs helping with insurance premiums and coinsurance and copayments, we have a greater population that's insured. So when we're coming out for site visits, there is a pretty significant push on program income because programs should be generating considerably more income than they have in the past. And so it's very important that when you have these systems in place to say we're enrolling patients, we're making sure that we're billing insurance, we're serving as a payer of last resort, the last step to that is saying that this is the income that's coming in from those insurance providers, and this is how we're reinvesting it back into our HIV program. That's really the final step of managing the client program. So just to kind of drive home all 4 sections in terms of what an enrollment process would look like. So you'd have a patient that enrolls initially and recertifies annually. During that enrollment, they need to be assessed and enrolled in any insurance program that they're eligible for. Outside of insurance, the patient should be assigned a level, and if they're above the federal poverty level, they should be assigned a cap on out-of-pocket charges that's based on income and their household information provided. If possible, insurance information and sliding fee scale placement should be entered into the billing system. Ryan White always as the secondary or tertiary payer. And then as charges come in, they should be billed to the insurance initially as applicable, and then the sliding fee scale would be applied on the amount owed by the patient after insurance has assisted. So the patient is billed for the amount owed based on their sliding fee scale, based on your nominal fee or your percentage of charges, and the grant would assist with the difference between the amount owed and the patient's responsibility. The patient charge is applied to the patient's cap on out-of-pocket charges. At 6 months, the program will check in with the patient just to make sure nothing's changed, just to make sure they're not now eligible for an insurance program that they weren't eligible for previously. And then the program takes the income from the patients that pay, from the insurance that pays, and they reinvest it back into the HIV program. So that would be what the full client management circle would look like if all of the pieces and parts are in compliance. And total compliance with all these sections then identifies and solidifies who is eligible for Ryan-wide assistance, regardless of the patient's income and insurance status. So I wanted to talk briefly about the patient education tools, and these are what is available in the folder that Samantha mentioned. So we have found our program personally that providing an after enrollment letter to identify the patient's information specifically is pretty helpful. Initially, we had an application that the patient would fill out, and they left with a fistful of paperwork that I think they probably promptly threw away. But what we started doing was walking them through the process, helping them complete the enrollment application, and then either providing them a letter on site if they provided all the information, or sending them a letter at home that states, this is the information we received from you, this is the income that we received. Based on this is your sliding fee scale, this is your cap on out-of-pocket charges. We identified the dates that they would need to recertify and re-enroll. We have systems in place to track those patients and know when they need to recertify and when they need to re-enroll. And we vigorously pursue, as HRSA likes to say, getting these patients enrolled and recertified in our grant. But we also give them that information, so the ones that can be proactive and are proactive will provide us the information, and we can just kind of knock them off our list. So here is just a picture of what the letter might look like. Ryan White obviously strongly discourages programs from sending patients to collections, and oftentimes, particularly larger organizations, it's kind of hard to turn that off. So I often encourage people to put in their letter to the patient, if you get a bill, please bring it in. I've heard programs say, in our own program, patients will bring in the 15th bill right before it goes to collections, or bring in the collection notice. So if you tell them up front, we're going to try our hardest to prevent bills from coming to you, but if it happens, here's who you need to talk to. Please bring this bill in, and we can help get it taken care of. That way it can be more proactive and not on an emergency basis. So we like to provide that information in our letter. I've seen programs give patients business reply envelopes to send in receipts or to send in invoices to help the patient track their cap on charges. I went to a site, Washington University. I told them when I saw this tool that I was going to borrow it, and I would make sure I gave them credit every time I used it. But they had a really nice form that patients would complete to monitor their own cap on charges. So if they received services in other programs, they could write down and kind of keep track of themselves what they were paying for out of pocket, and could use that as a tool to track their cap on charges. So I thought that was a nice tool as well. So I want to close out with two more case studies just to kind of drive the point home and discuss two types of patients that we really haven't discussed yet. So the first is a patient living with HIV who has an income of $5,700 and a household size of 4, and the patient is uninsured. So by all scenarios, this patient is the patient that's below federal poverty level that really needs the assistance of the Ryan White program. So when they come in for enrollment and eligibility, obviously based on their federal poverty level, they're not going to have a cap on charges, and they're not going to be responsible for their medical care. But you should walk through the process to make sure they're not eligible for any other programs. In a straightforward scenario, the patient receives medical care, they don't pay, and they're reassessed at 6 months. But what I wanted to walk through is now with ACA, particularly in Medicaid expansion states, You have to look at these patients, get them enrolled in Medicaid if possible. If Medicaid is not an option, getting the patient enrolled in a marketplace plan if that's available. And so this patient comes to your program, they receive HIV medical care without being assessed fees. The recipient's going to bill Medicaid and the insurance company for billable services. Ryan White funds will be used to help that patient with any copays or coinsurance. And this patient who's below the federal poverty level is now generating income for your program. So I can't tell you how many sites I've been on that are not measuring program income and don't feel like they have it. But now, in the era that we live in, patients who are below the federal poverty level could be generating income for your program. So it's imperative that in this day and age that Ryan White programs are really looking at who you're paying for with Ryan White funds. Are they billable providers? Are you billing insurance and tracking that income that's coming in and reinvesting it back into the program? Because that's a finding, I think, on almost every site visit I've been on in 8 years. I've maybe found 1 or 2 programs that are doing that. But particularly now with ACA and such a large patient population that's insured, programs really need to have a handle on how much money is coming in and how that can be reinvested back into your program to offer comprehensive wraparound services for this population. So I wanted to close with one patient. So this is a person living with HIV. Their annualized income is $80,000. Household size of 1, federal poverty level of 673%, and their cap on charges is $8,000. And say this patient has private insurance. So the patient has a copay of $40 for every medical visit based on your sliding fee scale. He's responsible for 100% of his copays and charges. You know, maybe he'll pay a cumulative out-of-pocket for the year of $500. And so this person still impacts your program, because if you're tracking program income as this patient's insurance pays, you will still be taking that income from his insurance and reinvesting it back into your program. But also, if this patient has something happen and cannot pay his copays, the patient shouldn't be turned away for services. By having a Ryan White grant, by being a Ryan White funded program, we are to serve the HIV patients that show up in our doorstep and make sure that they can receive outpatient medical care and then work with them. You can offer them a payment plan, you could waive copays, but if this patient's a Ryan White patient, they should still be provided care regardless of their ability to pay. So with that, I'll just reiterate what Samantha said, that fiscal health systems to sustainability is here to ensure the fiscal sustainability of Ryan White funded recipients. So they participate in regional trainings, they provide technical assistance and online learning such as this webinar. So I've worked with them for a little bit. They offer a lot of great resources for organizations who are trying to strengthen and implement these systems in their program. So I thank you guys for your time today, and I guess I'll turn it over to Samantha.
Thank you so much, Jenna, and thank you everyone for all of your questions. So as I mentioned, we're holding them towards the end. I so far have 3 pages of questions, so I'm hoping that we're going to be able to get to all of them. Again, if we don't get to your question, or if it's something very specific to your program, we'll get back to you personally, and you can always email me. My email is just Samantha, SAMANTHA, @healthhiv.org, and we intend to answer every single question that was asked here. So I'm going to start asking Jenna some questions, and just for organizational purposes, I've organized them according to eligibility determination, caps on charges, and sliding fee scales. If you have other questions, please continue to ask, and we'll try and monitor them. And just a couple other housekeeping things, again, since I've seen some people asking about it as the presentation is going. This webinar is being recorded. We can send it out via email. It will be on the Target Center and on our website. The forms that are in the folder icon to the right that also have the slides are meant to be individualized. You can use the language that you want. You can include services that you want. This is really just to give you a starting point to see what some other folks are doing. So with all of that being said, Jenna, I'm going to get started asking you some questions that you can answer. So the first is, so this is, again, the eligibility determination section. Okay. Can you complete sliding fee scale kind of determination prior to receiving eligibility determination documents?
Can you complete signing?
So if you haven't really finished someone's, yeah.
I guess it would depend on what information you have. I mean, if you don't have proof of residency, or, I mean, you would definitely need to have income information. Unless you are just taking a patient at their word, which I think is strongly discouraged. I think you would need to have at least income information, and if you require household size, then you would need that information as well. I don't know if I'm getting at that answer, but...
Yeah, I think and the answer Francesca just specified for us, it's based on kind of verbal attestation, not documentation. And so she basically wants to know you can't really do it until you have that documented, what their income level is.
Not really. I mean, yeah, if a patient has no income, then it's fair for an organization to have a statement that the patient fills out that says, you know, I have no income and I'm meeting my expenses by living with a family member or living with a friend, or having some kind of format that the patient fills out if they don't have actual income by a pay stub or checks or anything like that. But for the most part, other than that, you really need to have documentation of what their income is before you complete that process.
Thank you. And how are individuals supposed to prove family and household size?
That's a great question. So I will say for my organization personally, we have always tried to do what is best for the patient if possible. So if the patient has a roommate that's living with them but doesn't really impact their income or expenses, then we haven't really counted the roommate. But in the face of ACA, in the face of Medicaid enrollment, where that information is tracked more closely when patients are applying for insurance, we have tried to stick with the taxable household. So whoever would file taxes together, that's what we try to get proof of, whether that be kids or a husband or things like that. We just try to stick with who would be in the taxable household.
Great. And can you clarify when you would use just individual income and when it would be household income?
That's a really hard question. That's up for a lot of debate depending on who you ask. Again, we have tried to steer away if they're not part of the taxable household. And so if they're not filing taxes together, we typically do not count them. You know, when a person has kids and dependents that are going to be part of their tax liability, if they're going to file taxes together, then we do count those. But if you've got 5 people that are living together and that's it, and they're not really participating in expenses together and they're not filing taxes together, then we really typically just count the patient. Because when that patient applies for an exchange or applies for a Medicaid insurance, then it's really just going to pick up the taxable income, and so that's who we typically accept income for.
Okay. And if participants say that they don't have proof of income, how can you work with them to try and determine what their income is?
Well, that's a great question. So I guess if the patient doesn't have, you know, if they're being paid under the table or if they're being paid a way that is not being picked up or taxes or whatnot, I think you as an agency have to determine how you're going to track that. If you're going to have a form that the patient completes that says this is about how much I receive per month. I mean, I think the take-home message with all of these questions is that the recipient has to make a good faith effort to do what they can to get this information from the patient. I mean, we're dealing with people that aren't always compliant, and so they're not always going to provide the information that we have to have, and we just have to show as recipients good faith effort to get this information. HRSA calls it vigorously pursuing, and that is defined by your organization. So having a policy and procedure that says we're going to go after this information 3 times, and if we can't get it, you know, the patient's still going to be seen because we're a Ryan White program and we can't turn them away. So you really having a policy and procedure for your organization that defines what you consider vigorously pursuing and how you feel like you can defend, you know, this is the information that we're getting from the patient, whether it's a signed document that says this is how much they make a month or some kind of Excel file that you guys put together, you know, with them saying how much income they make a week, whatever you feel like you can defend and I think that's up to your organization to have a policy and procedure that says this is how we're going to move forward.
Great, thank you. We're going to move to caps on charges now. And I want to start, we had a question on, are caps on charges payments or is it charges? And we just want to reiterate that it's not it's what the patient has been charged. It doesn't refer to what the patient has paid. So you cap it based on what they've been charged, not the money that you've received back in the form of payment. So I just want to clarify about that before we continue. That's what caps on charges refers to. So our first question about this is, there are a lot of questions on so if ADAP is paying for premiums, is that included in the cap on charges? We have a bunch of ADAP related questions here.
So I would say no. Whatever the patient is responsible for, if the Part A or B is actually paying their premiums or paying co-insurance or co-payments and the patient's not responsible for them, then I would say no, that would not apply to their cap.
Okay. We have a lot of questions here on, how to track clients' charges across services, and I think that we addressed that in the webinar. If you have any other questions about that, feel free to get in touch with us personally, and we'll talk with you a bit more about that. But I just wanted to say we saw your questions. We hope that they were answered, but we're going to go to some others that haven't been answered yet. Do vision and dental insurance premiums count towards the cap?
Vision and dental insurance count towards cap. I would say yes. If the patient's paying it out of pocket, I would say yes, because those can definitely impact their HIV care. Dental, of course, is a huge part of Ryan White services is supporting oral health for patients. So if patients are paying dental and eye insurance out of pocket, yes, that would go towards their cap.
Okay, and there are other questions on the services, a lot of services, what would count towards the cap? So we have questions here, does the cap on charges cover mental health services? Would it cover, for example, how do you deal with case management versus medical case management? So can you just define what kinds of services would count towards the cap?
Well, I would say anything that is HIV related. So if there are services that would be covered by Ryan White or are allowable services to be covered by Ryan White funds, then I would say that if patients are paying a portion of those charges, such as mental health is such a huge issue for our patient population. If they do have some co-payments or funds they're paying out of pocket for those services, then yes, they can be counted towards their cap. It's really anything that's related to their HIV care, and that would be defined again by the recipient. We have involved our medical director in in determining if some things are HIV related or not, and sometimes that has to be done on a case-by-case basis. But we just have kind of a policy that says, if the HIV infectious disease provider can defend that this is an HIV-related issue or can exacerbate HIV, then we would connect that to their HIV disease.
Great. We have, so just another question, but I think a lot of people are asking this, so we're going to kind of reiterate what we said already. So if the cap is met with charges, not what patients pay out of pocket, does that technically mean that a patient doesn't have to pay anything as long as charges are submitted?
Yes, that is not the way the legislation is written is that you have to keep track of charges as a recipient, not what's paid. So what's paid is really on the patient to make that happen. What you're covered by is that you have collected information based on what the patient has been charged, and you have applied that towards your cap. That's kind of where your responsibility ends.
Okay. And then the last question that we have on caps on charges right now is, so a patient was seen in July and charged a copay. They bring in a bill showing that they had received services in May and met their cap at that time. So should they not be charged a copay for July, even though they didn't bring in the documents until after the date they were seen?
So, yeah, that's a good question. And there is a lot of backdating that goes to this because you're not going to receive everything typically upfront on time, in any measurable way. So when the patient brings in charges to us and we're keeping track of that for a patient, at whatever date is on that bill, that's typically what we will identify as the date they met their bill. So in that instance, if the patient's coming in August and bringing this May bill, we would backdate their meeting their cap in May, and then if they had outstanding bills, we would help them with those.
Okay. We have another good question that just got asked on how you determine a year for, so we kind of say that whatever you meet a cap on charges in a given year, how do you define what that year is?
So it really is different for everyone, and that's going to be different for programs. We're a program that has been in existence for 15 years. We have patients that we're still seeing that have been enrolled in our program for 15 years. So everybody's year is different. If you can find a way to get everybody on the same year, congratulations, and I would love to talk to you, because I think that would be the best for everybody. If everybody enrolled in February and then they re-enrolled in the next February, that would be fantastic. But it's case by case, and that's why we have a pretty significant system in keeping track of all this. And so our patients have we have a spreadsheet that keeps track of each patient, when they enroll, when their date is up. So it's really a year from when they enroll in your program. That's how long that lasts. And then 12 months later, that's when they re-enroll. So it's not a fiscal year for us. It's not a calendar year. It's just the date the patient enrolls is their start date, and 12 months from that date is when they need to recertify.
Okay, and you actually kind of led us directly into our next question, which is what kinds of systems can you use to track caps on charges, and can CareWare be used for any of this?
I know, that would be great, right? We do. The problem with using CareWare is that we don't have a good way to flag if a patient's getting close, or to say, ding, 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 the patient's met their cap. So we really haven't found a good way to use CareWare yet. We're trying to move there. We're trying to move to a more of a database model. But really what we do is we have a spreadsheet for each patient that has a cap on charges, and then as they bring stuff in, we're just adding it to that person's spreadsheet. So it's a little cumbersome. It's not a huge population. Like I said before, we have about 300 patients that have a cap and about 87 that actually meet it. So each patient, we have an e-file for them, and when they turn in charges or when we have charges, we'll enter them into that spreadsheet and keep track of it that way. But honestly, I don't really have any magic system outside of just using Excel or using an Access database to keep track of that information.
Great, and we just got one other question on, what subgroup of patients are you applying caps on charges to? Caps on charges, so again, since you can't charge anything for patients at or below 100% of the federal poverty level, their cap on charges is 0. Anyone above the federal poverty level has a cap on charges. There is no, I know that there are some kind of lower eligibility in terms of federal poverty level for certain parts, but even anywhere above 300% of the poverty level, they still get a cap on charges of 10% of their annual income, no matter how high that annual income is. So just wanted to answer that question before we move on to the next section, which is related to sliding fee scales. We had a lot of questions on, is a sliding fee scale mandatory, and what do you do? Is there an exemption for charging providers that do not charge for services for anyone that they see?
So I don't think there is an exemption, and the sliding fee scale is a legislative requirement. So there's no exemption from that. I don't understand the second question.
It seems that there are a number of people, there were a number of people who were basically saying that some providers opt not to charge patients any out of pocket. So they don't charge any of their patients anything out of pocket. So is there an exemption for providers who decide to do that?
Well, I would say no. I guess if they're a Ryan White provider, they're technically out of compliance. The requirement from the legislation is that a patient under the federal poverty level shouldn't be charged, but a patient above the federal poverty level should be charged for services, even if it's just a nominal fee, $1, whatever. They have to be charged for services. So, you can't really excuse a person who's not in compliance with the legislation for the program.
Great.
Right.
And while we're on that, yeah, and I agree with you also, by the way, on compliance.
Thanks.
So going to can you give some examples of what nominal fees are? You know, how does someone choose a nominal fee? And if, for example, we get this question a lot, if you're providing, you know, typical core medical services versus if you're providing dental services, can those nominal fees look different?
They can, and I think I've seen the most percentages at dental programs. Oftentimes I'll get on a site visit, I'll get a fee schedule, and you'll see what the full charge is, but if the patient's Ryan White, we're going to charge them this amount, and it's typically a percentage of the charge. That's the hard thing I think about the sliding fee scale is this just is not defined, and nobody says this is what you have to charge. I think it's really at the discretion of your program, and maybe even what you think is realistic for your patients. You know, is $1 make sense for 100 to 150% of the federal poverty level? Does $5? I mean, there's nothing that defines this is what you have to charge. It's not defined anywhere. I looked. All it says is that you have to have a sliding fee scale, and then if they're under the federal poverty level, they're not charged. If they're above the federal poverty level, they're charged something. So there really isn't a magic number or any real direction in terms of what you have to charge. It's that you have to have a system in place to charge, and it's at your discretion what your sliding fee scale looks like.
Great. And on that note, can you have a sliding fee scale that only has two levels, such as below 100% and above 100%?
I mean, I don't see why not. I haven't seen one necessarily that simple, but it would be, I think, in compliance with what the legislation says is charging someone under, not charging someone under and charging someone over. So I think if that's what works for your organization, it sounds like it would be in compliance.
Okay. And I also want to add to that, I think it would be in compliance, but it's also important to remember that folks do really have different abilities to pay. So someone at 300% would really be, would be better able to pay for services than someone who might be at 110%, which is why, it would be in compliance, but it's important to think about those kinds of issues as well.
Yeah, exactly.
The next question, if a patient has no responsibility after the insurance pays, must we still charge a nominal fee? In this instance, the Part B program covers copays, so most of the patients wouldn't have a copay.
So I think what that would involve, that's a great question, and it may be that Part B would pay less of the copay. In these scenarios where if the requirement is that the patient should be charged for a portion of their service. So in a scenario where if you had a $40 copayment and your nominal fee for that patient was $5, then charging that patient $5 and having Part B pick up the $35 outside of the $5 that the patient should be charged, I think that would be more appropriate, because really Part C and D are supposed to charge patients if they're above the federal poverty level. So it may be discussions with Part B that they pay a percentage of the copayment rather than the full copay. And that's why I mentioned earlier, programs are typically better at just not charging patients anything, because there is a lot of systems that have to be in place to make this happen. But the requirement for legislation is that patients who are above the federal poverty level are supposed to be charged.
Great, thanks. So we have a bunch of questions that are related to the kinds of services that sliding fee scales apply to. So this question here is, does it apply to all services or just those that have costs associated with them, like medical care but not case management?
So if you're saying you're not billing for medical case management and you're not charging patients, do you now have to charge for them?
Right.
Is that the way you interpret that?
It seems like that's the question. If it's not the right interpretation, if the poster wants to type again, then we can look at it again. But to me, that's what it meant.
Okay, I would think that the services that you would be charging a patient for would be billable services. So if this is something that you would bill insurance for, then that would be what a sliding fee scale would be attached to. If there's, if you're providing non-medical case management and that's not a billable service, then you would not need to extend a sliding fee scale to that service. I think the sliding fee scale is really only applied to billable services.
Okay, great. And how can you apply how are charges associated with labs for HIV care handled? And this is a question both for sliding fee scales and for caps on charges.
So they're HIV-related labs. Is that the question? Okay.
Yeah.
So I will say for most organizations that I've seen that have a pretty good sliding fee scale in action, it looks like a percentage instead of a nominal fee. So I think sliding fee scales for nominal fees for a medical service, like if this patient comes in, sees an HIV doc, pays $10, that typically works. But when you get to labs and where labs could be different amounts and different labs are ordered at different times, I've often seen programs do a percentage. So that's when they may say, the patient gets a set of labs and the patient would be responsible for 20% and the grant may assist with the remaining 80%. So the patient would still have some responsibility for the lab bill, but the grant would assist with a good chunk of the lab bill based on that sliding fee scale.
Great. And we have a question here that's related to double dipping. So if a provider's salary is covered by the program for administration and kind of program direction, can Ryan White funds still be used to assist patients with the remaining copays?
Okay, so if you have a physician that's their medical service service time is supported, or just their administrative time?
It doesn't say. It says a provider salary is covered by the program for administration and program direction.
Okay,
so I guess we can answer both of those questions, maybe, if there's
right. Yeah, so I think if the billable provider is only on the grant for administrative or CQM or something like that, then grant funds paying for the copay is totally acceptable. That wouldn't be double dipping because their medical time wasn't paid for up front. I think with an organization where you're paying the provider for 4 hours to come in and see HIV patients for 4 hours, then you've paid for that up front, and so then it would be, I think, double dipping if you then paid that copay because the provider was already paid for.
Okay, great. And I'm going to go back. I have a question here on eligibility, but I think it's a really great question, which is if a patient is eligible for Medicaid but doesn't want to enroll, you can't require that a patient enrolls, can you?
That's right. So, when ACA was starting to roll out, there was a lot of policy notices that came out about that and a lot of discussion in terms of the monitoring standards. And that's, again, where your policies and procedures are very important. So the Ryan White buzzword is that you're going to vigorously pursue enrollment for patients. Ryan White is to be the payer of last resort, and so it's on the recipient to attempt to get the patient to enroll in any eligible programs. But obviously, we can't force them to. And so that would be documentation on your end saying, we are asking patients 3 times. We're educating them about, the fact that inpatient would be covered, or that they would receive other supplemental services that the Ryan White program can't assist with because we can only help with outpatient. And the patient is still refusing. I would have the patient sign if they would, or have somebody witness it, and then you have documentation that says you've tried, you've vigorously pursued, and that patient will just not comply. That covers you, that you've done what you can to get the patient enrolled in any eligible program they might be in, but then, you can continue to provide care to that patient because patients can't be turned away for services.
Okay, thanks. So those were all the questions that we had time to write down during the presentation. So we're going back through the chat box now. So give us a moment if, we're trying to find questions. So we have always been told that we couldn't assist with Medicare or Medicaid copays as it was considered double dipping. Can you please clarify that?
Well, I'm not an authority on this by any means, but I mean, Medicaid to me and Medicare is different, and Ryan White exists as a supplemental program to that. So I haven't heard that before. I would feel better if Samantha and that team went back and maybe asked a policy analyst or someone at HRSA to clarify that. That has never been my understanding, that the Ryan White program is the payer of last resort, so we wouldn't pay before Medicaid, we wouldn't pay before Medicare, but if there's patient out-of-pocket responsibility after those programs, it's my understanding that Ryan White is there to help those patients.
Right, and I agree with you. Again, Ryan White should always be the payer of last resort, and I haven't seen anything that considers it to be double dipping, but we can certainly go back and check the guidance and get back with the person who asked that question. Okay, here's a question that I think a lot of people on this webinar might feel similarly to. How can you reassess income yearly, or, I mean, technically every 6 months if you're really looking at recertification the way it's supposed to be practiced, if you have 2 support staff for more than 750 patients? And I know this doesn't have one answer, but if you can talk about some ways that people that would be great.
I would say that this is a struggle for everyone. There is a lot of manpower that goes along with this. I will speak to what our program does. We have about 1,300 patients now. We have 2 enrollment and eligibility staff, and that's what they do. They check to see what patients are coming in. They try to be proactive and get patients enrolled and re-certified. They meet with patients at intake, and they do everything that they can to keep patients enrolled. We also involve our medical case management and non-medical case management staff to kind of monitor these patients that are coming in, if they're walking in or if they're being provided a medical service. I think that this has to be a priority of the program. I mean, you can use Ryan White funding to support these efforts and to make sure these systems are in place. 2 support staff, if that's all they do, they can probably make it happen if they're working with other staff. But it does require manpower. Maybe that if you have access to program income, maybe using program income to hire enrollment and eligibility staff. I don't know the specifics of your program, but if once a lot of the work is up front, getting all the systems in place, and then it kind of, I don't want to say manages itself, because you definitely need people to do that, but there's a lot of work up front, and then once the systems are in place, having a system where medical case managers, non-medical case managers, benefits managers work with patients to get that information in is really the only way you can do it. I mean, some people do try to have electronic systems where patients can get in, but then you've got to protect that information, so it really has to be creative on your stance as a program on what's going to work for you and how you're going to be able to incorporate it.
Great, thanks. We have another question here that's a little bit off topic, but I think it's a really good question. What would you do for proof of income if a patient lives with their parents, uses their insurance, and hasn't disclosed their status to the parents?
That's a good question, and I would just have a form that the patient fills out that states that. I mean, I think when you get into issues of disclosure and things like that can result in all kinds of issues, I think having something that the patient signs that says, I don't have income, I live with so-and-so, they're helping me with my expenses, I think that person, if they don't have income themselves, it could be considered under the federal poverty level, and you have to treat them that way. It really will be up to your policy and procedure on how you do that. But I think if you have a form or something that just documents that you've talked to the patient about that, if you have a form or something that just documents that you've talked to the patient about that, this is how their needs are being met, but you're not going to get income from the family because of these other issues, I think that covers you as a recipient, that you've done what you needed to do to talk with that patient, enroll them, and get them covered for care.
Okay, thanks. That sounds great. I'm going through the rest of the questions now, and I think, hold on one second. Here's another one. If there's no billable third party to charge for case management, would you have to charge a fee?
I would say no.
Okay. Yeah. I know we talked about this, but we're getting so many questions on.
I think it would just apply to billable services. Like if you have insurance in your state that you can bill medical case management to, then it may apply to case management. But if there's not billable providers, insurance, Medicaid, Medicare that are paying for that service, then I don't think you need to slap a sliding fee scale to it.
Okay, great. We only have time for a few more questions, so I think we're going to take 2 more and then, just talk a little bit about some next steps for folks. So there are a lot of Ryan White providers that don't charge patients. This happens in a lot of cities. We go to trainings all the time and people say they don't charge anything. So if we start charging our patients, then they're afraid that the patients will either go to other providers that don't charge, if that's an option, or if they're really the only providers available and they just haven't been paying for years, how do they suddenly get them to start, contributing to their medical care?
Yeah, that's a great question, and that's really hard. I've been to a lot of organizations that, that's typically, it's easier to not charge anybody anything than to put all of these systems in place. But when you get down to it and you look at the legislation and you look at the program guidelines, it's really a requirement that these systems be in place. So technically, the programs that are not charging or are extending that to patients, they're out of compliance. So they're going to get slapped with the site visit, and they're going to have to make those changes as well. So I think discussing with your project officer would probably be the first place to start. I sympathize with you. I understand that's an issue. I've been to several programs that have asked, well, everybody's just going to go here, but really they're out of compliance. And as soon as they have a site visit or the project officer gets wind of that, they're going to have to change their processes as well. So I would say that would really be more of a discussion with your project officer on how they feel like you should handle that in terms of other grantees.
Great, and I think this is going to be our last question just because we're getting out of time here. So, and this is around eligibility as well and kind of participation in the program. So you have a patient who doesn't agree to sign up for insurance. They sign a document basically so you can say that they refused. Are they still eligible for Ryan White, and how does that affect the kind of sliding fee scale level that they receive? So this is sort of 2 separate questions. I'm combining them into one.
Okay, so I think if the patient refuses to sign up for insurance, like you said, having a form that says that you've educated the patient, they've refused. I think the sliding fee scale is separate. The sliding fee scale would still be applied to them based on their poverty level, not based on their insurance. So if their income was at 200% of the federal poverty level, then that's where you would place them on your sliding fee scale, and then you would bill them for services based on where they fall on the sliding fee scale, and the grant would assist them. As a Ryan White grant recipient, we can't turn patients away. So as long as you have a way to show that you've educated the patient and have tried to pursue enrolling them in anything eligible, after that, really, you're a grantee, they're a patient, and you have to cover their medical care.
Okay, thank you very much. And I know there are some questions on here that we didn't get to. It's because I think that we need a little bit more information before answering them, so I don't want you to think that we're ignoring them. Again, I'm typing my email address right now. You can all hear me. If you have any other questions, if we didn't answer yours, please feel free to email us. We will try and get back to all of your questions if we can. Again, the forms that we have and the slides that are available for download, you can share with whoever you want to. The tools that we have in terms of letters for patients, those again are just meant as a sample. You can customize them for your clinic if you have different policies. They're in the little folder icon at the bottom right-hand corner of the screen. If you have seen some things in this today, in this presentation, and you're like, wow, I don't know that we're doing this right, or I have some other follow-up questions, you are more than welcome to request technical assistance from us. Technical assistance is free of charge for any Ryan White funded organization. So you can just, again, shoot me an email and we will follow up with a phone call. There was just another question of when the recording of the webinar will be available, where it will be available. We will try and get it done by next week. We have to make all of these 508 compliant, so sometimes it takes a little bit to be able to do that. It will be on the Target Center. It will also be on our website. We will send a follow-up email to all of you when that has been made available. I hope I answered all of your questions. You asked some really, really great questions, and clearly this was a needed presentation. If you have any other topics that you're interested in having webinars, please, please, please email me. We're creating this because we know that people are interested in it. We have another one on preparing for a HRSA site visit that's going to be on June 23rd. I mean, anything that you think is a needed topic, if you've been having challenges with it, we're really here to meet your needs, and I'm completely serious about this. Please send me an email if you have any questions. We are very, glad that you could stick with us for the entire hour and a half today. And Jenna, thank you so much for your words of wisdom. I know that I threw those questions at you from left field, so thanks for playing along.
No problem.
And that's it, everyone. We are going to stay on for a bit so we can capture all of the questions. But thank you very much for participating, and I hope you enjoy the rest of your day. Take care.